Thank you very much for attending APASL 2024 Kyoto, the Center of Hepatology. We'll now start the session, the state-of-the-art lecture chaired by Dr. Osamu Yokosuka.
Well, I'm Dr. Yokosuka from Chiba University, and I'm going to chair the session of state-of-art session by Professor Tawandi. And Professor Tawandi is a professor and head of Division of Gastroenterology, Department of Medicine, Faculty of Medicine, Siri Raj Hospital, Mahidol University. And he's working for a long time at the Siri Raj Hospital, Mahidol University. And he is currently a professor of gastroenterology and head of division of gastroenterology since 2008. Anyway, he studied at Baylor College of Medicine for 2 years, and he was president of APASU Bangkok 2021. And he's going to talk about can blood-based biomarker SCC surveillance replace ultrasound? And Professor Tawandi, please.
Thank you, Professor Yokosuka, for a very nice introductions. And also, I would like to extend my sincere thank you to Professor Sheena and the organizing committee for this invitation to the Apostle 2024 in Kyoto. So I'm going to talk about whether we can move from the ultrasound-based screening for HCC to blood-based screening. Here's my disclosure. I also work on the research regarding the diagnosis of HCC with Roche Diagnostics and also Fujifilm Vehicle that made relevant to this presentation. So my topic today is going to cover on the rationales and guidelines for the current guideline for HCC screening and the qualities as well as adherence to the current guidelines in terms of HCC surveillance. Then what if we can move from ultrasound-based screening to biomarker, which is the one shot. So every patient must come in for follow-up and blood test, and then just one stop, and they can have the HCC screening at the same time, and the conclusion on the future aspect. Shown here is the prevalence of the incidence of HCC. You can see that in Asia Pacific country, we are in the epicenters of HCC country. And the risk factors among nowadays is chronic viral hepatitis that include hepatitis B in most of Asian countries and hepatitis C in Japan, in Korea. And in the future, we're going to have more on alcoholic and fatty liver related complications. So if we can detect HCC at the early time, we can have curative treatment, and the survival can be up to 40 to 70%. However, most of the patients present at the time they have clinical symptoms, where usually it is advanced, no curative test, survival is very low. This is the current guidelines among 3 continents for the guideline. For SLD, initially they hold the AFP, but with the recent guideline, they combine ultrasound with the AFP. The Apostle also include ultrasound and AFP, where ESO just use ultrasound at the screening, and interval going to be every 6 months. So actually, hepatocellular carcinoma is among the, you can define the target the patient that at risk for the the developing hepatocellular carcinoma is not the general population. This is among the high-risk population, but still we need to certify and modify these. Even this is the most recent one, but with the treatment of your hepatitis B, hepatitis C, you see that previously the previous guideline also include F3, Hep B with after cure, but with the recent guideline, the SOD guideline, remove F3 after cure. So every study regarding surveillance for HCC, you see that the earlier, the better. So if you can detect earlier stage of the HCC, the survival going to be higher. You can have curative treatment, and the outcome is going to be better. Now, when we look at the sensitivities of the current guideline, where ultrasound is the main screening tool, you say that for ultrasound alone, the sensitivity for detections of HCC is going to be just 45%. When we add alpha-fetoprotein to the ultrasound, the sensitivity can go up to 63%, but it's still unacceptable. However, with this implementation, the surveillance shows early detection with more patients receive curative treatment, increase overall survival. However, there are the drawbacks of the screening that include cost and also some harms, especially the financial and also psychological harm by false positives of the screening. So you need to balance between the benefit and the harms of these screening tools. And then in between, you can balance by taking into account the risk, the liver dysfunctions, also the age, sex of the patients. Now, with the ultrasound, this is a retrospective study from the US looking at the ultrasound performed by radiologists. You will see that up to 20% of the ultrasound, even done by specialists, did not qualify for adequate exclusions of HCC. Moreover, the surveillance with the ultrasound over the time, up to 20% of the ultrasound can have less accuracy in terms of detecting HCC, especially in the patient with advanced fibrosis or the patient with severe obesity. And then with adherence, so with combinations of ultrasounds and AFP, that means you got to go for blood test and then you got to schedule for the ultrasound with the radiology. So you need to have two tests at the same time. So the adherence, even the ultrasound alone, again, is very low, just about 50% of the patient that eligible for screening. This is a summary of the limitations of the ultrasound, with the sensitivity low, accuracy depends on the radiologies and also depends on the situations of the liver, surveillance harm with some false positive or indeterminate result, and low adherence in general, just about 50%. So there is a huge gap for HCC surveillance. With the current tools, it is still suboptimal in terms of performance of the surveillance program. In terms of stratification of the patient at risk, we need to improve this assessment and certify the patient accordingly. Performance of the current screening test is still suboptimal. And also the most important thing is uptake of HCC screening. So the ideal test is going to be more sensitive, more specific, and better acceptability by the doctors, by the patient themselves, easily to access and widely available, and without more harm to the patient. And lastly, is going to be cost effective and can convince the payer to pay for the screening. So nowadays, there are blood-based screening and image-based screening. So talk about the effectiveness. So if you have the taste that's very sensitive, but adherence is low, you got low effectiveness. But the best test could be the very sensitive and high adherence. That could be the best possible test that you can offer to the patient at risk. So now, when we look at image-based and blood-based screening, for interest of time, I will not touch upon image-based screening that include two-phase CT scan, abbreviated MRI, and many protocols of MRI with or without contrast. Now, when we look at blood-based screening, it is depends on individual markers, biomarker panels, and genomic markers. Nowadays, the top three of blood-based markers, including AFP, APL3, and PIPCA2. These three are now on the market. But there are also many investigational biomarkers that can enter into the screening program. And the biomarker panel, we have known about Gallup score, we have known about Gallup score, and many more scores that are going to come in the near future. And more recently, genomic biomarkers that include cell-free DNA and many genetic biomarkers for screening. This is the summarize of phases of biomarkers for HCC study. AP has been implemented for the phase 3 study. Actually, there is no true phase 3 study because for phase 3 study, you need prospective control with the standard of care. So some that can be applicable for phase 3 study, like Gallup score, has algorithms I'll touch upon next slide. And many of biomarkers or biomarker panels nowadays is still in phase 1 and phase 2 studies. This is a head score. This is among the study in HCC early detection screening. Instead of using the one-time AFP, they use the delta change of AFP plus age and ALT and platelet count. So you see that this score offer so they store the blood and they look at the data or the analysis. So the score and then retrospective test. So the score can detect SVC 6 months or 12 months, 24 months earlier. So you see that as compared with the ultrasound alone, it's just a little bit better, but it's still unacceptable. We need to modify. We need to look for more adaptation of this score. Then another score with the same investigators. This is called, actually the original score was the Doylestown, and then they got Doylestown plus algorithm that includes age, log, AFP, PEG, precipitate IgG, and fucosidate kininogen. So again, the score is for early detection of SCC 0 to 6 months before. It's just a little bit better as compared with the AP, APL3s or not the DCP. So it's not acceptable for screening or replacing the ultrasound for screening as a standard of care. Now, with the recent score, there are a lot more studies regarding Gallup score. Gallup score. The Gallup score composed of AP, APL3, and PIPCA2 plus 8 and 6. 8 and 6 is just nothing because there is no cost. So with this algorithm, you can say that the GALA score can detect HCC at early stage, that much more sensitive as compared with individual biomarker. But please bear in mind that this is not prospective surveillance study. This is just you have case of HCC, you have control, and you have to define sensitivity and specificity of the test. It's not in the real life that you screen the patient with this score. Now, the good thing for GALA score is you say that among different etiology of HCC, hepatitis B, hepatitis C, and non-viral, you see that the sensitivity of GALA score remains quite similar in both viral and non-viral. Again, the same investigator back into the head score, they also did the so-called phase 3 biomarker study, but my conclusion is not a true phase 3 study because they store the blood and then they look back and have retrospective look at the incident of HCC, and then they look at whether this score can detect HCC 6 months before the development of HCC. So again, the GALA score, head score, did not perform as well as the original study. We, with many centers in Thailand, and also in Hong Kong and in China, did another score called GAD score. This is the compositions of AFP, DCP, age, and sex. So we did not perform AFP-L3. So this formula, when you look at the GAD score, the sensitivity of detections of early stage HCC in the development cohort and validation cohort is quite the same. So usually the sensitivity is more than 90%. But again, this is case and control. It's not prospective study. Then when we look at the comparison between GALA score and GALA score with the same sample, so we use a GALA score from another company in comparison, you can see that. So without AFP-L3, GALA score did not compromise the sensitivity. So it's quite similar between GALA score and GALA score, but please keep in mind that this is the case and control. It's not the prospective surveillance. Another study, this is more sophisticated now. So they use multi-target HCC blood test. So this is a study from another centers from, again, from the US, looking at the multi-target HCC blood test. So in this study, they look at the multi-target HCC blood test compared with the GALA score. So the multi-target HCC blood test perform better than the GALA score. But when you see multi-target, that means there are so many biomarkers and also cell-free DNA including into the study that include investigational biomarkers. Now, in summary, for surveillance tests for early detection of HCC, above the standard of care, the ultrasound plus AFP. So this is implemented in every societal guideline. AFP-L3 individual PIPCA2 perform a little bit below than the ultrasound plus AFP. Multi-target algorithms, GALA score is still on the tracks of development. Also, Doris Channel Plus also still is performed just above 90%, but still we need prospective study. Now, with the availability of low-cost liquid biopsy. So this liquid biopsy that include cell-free DNA, exosome, many circulating cancer cells. With this availability, it can be useful for detection of SCC at the earlier stage. However, in order to design a good prospective study to confirm whether using blood-based biomarker can be comparable or better than the current ultrasound and AFP, this could be the problem. So you need to combine all of these markers and compare with the standard of care. But the problem, though, in this arm of standard in the arm of biomarker, so whether there is any ethical issue on deleting ultrasound in this arm, or you just design the biomarker in addition to the ultrasound. So it's going to be quite difficult until you can prove that the prospective study with biomarker, maybe in addition to ultrasound, can be at least as sensitive as the ultrasound or more sensitive than ultrasound in order to convince the IRB to approve these kinds of prospective phase 3 study. However, with the availabilities of genomic biomarker, for example, this is cell-free DNA. This is another study from the US looking at the cell-free DNA biomarker and see it's going to be quite sensitive in terms of detections of SCC, but still it's too early to tell. So the good news for us is, you see, there are many commercial products that jump into the market to prove that there could be the alternative for screening of SCC that include from Roche, include from many, this is cell-free DNA. So many methylation markers that will be included into this kind of screening tools. And this industrial sponsor might drive the rate of SCC screening program. However, if we have to design the study, we need to have at least non-inferior to the standard of care that we are available. Then we need to take into account that even in the arm of in the control arm with biomarkers, they don't contaminate with the ultrasound or AFP where it is available everywhere. So it's going to be very difficult to design and perform these kinds of prospective study. However, this is just a few weeks ago regarding the screenings for colorectal cancer. You can see these two studies published in the same issues of New England Journal of Medicine, where the FIT test is the first biomarker test that used for CRC screening. So they compare the next-gen multi-target amplification of stool DNA compared with FIT test. So the next-gen outperform the FIT test. And then instead of using stool, another study looking at cell-free DNA. So cell-free DNA can detect any stage of colorectal cancer at about 87%. So this is even the tumor in the lumen. So I think in near future, we can have something like this for screening of SCC that would be much better for us and at an affordable cost. So in conclusion, ladies and gentlemen, SCC is still leading cause of cancer-related mortality in our region. Early detection associated with improved survival. Currently, semi-annual ultrasound plus AFP is the standard of care, but it has several limitations, and it also its effectiveness in terms of screening. Biomarker and biomarker panels seems to be very promising, And it can be one-stop service because everyone must come for a blood test every 6 months, for example. And we need more prospective data to prove that these kinds of blood-based screening can be equivalent or superior to the ultrasound-based screening. And these tests require mature, well-powered phase 3 cohort to facilitate validations of the candidate biomarkers or biomarker panels. And moreover, we don't know how many going to be false positive or false negative. That will be a next thing to consider regarding recall policy. With that, thank you for your attention. Thank you.
Thanks, Professor Toandi, for a very nice overview of the blood-based biomarker for ACC. And then, yes, Professor Kadi, Dogmezi, please.
Yes, thank you very much, Professor Tani. Excellent speech, really.
Thank you.
In order to detect the early stage of hepatocellular carcinoma, of course, surveillance is very important. In Turkey, our strategy is alpha-fetoprotein and ultrasound in every 6 months, as you did. And also, we have to check DCP and also alpha-fetoprotein L3. But the most important thing for early diagnosis, this is not your topic, but I would like to tell, MR, contrast MR is very important. We perform in every year MR, and even alpha-fetoprotein is not high. Even other biomarkers normal, and we have to perform MR in every patients with chronic liver disease. And also, I would like to tell that in our clinic, in gastroenterology department, we perform ourselves ultrasound. Because my professor Okuda, my mentor, during my training at Chiba University, he told me that, look at Kadir, ultrasound is a stethoscope of gastroenterologist. And I brought this item to the Turkey, and I taught all the Turkish gastroenterologists ultrasound. Ultrasound is very important. Although for the early detection of the hepatocellular carcinoma is not so sensitive, but we have to perform ultrasound in every patient. Thank you very much.
Thank you. Just one thing, is all those investigations reimbursable by the government? You perform the MRI every year, perform the
yes, every year.
Every year, that then it was reimbursable, right? That you got reimbursed by the government, or the patient have to pay by themselves?
The government pay everything. If the patient has the medical insurance, then okay. Because all the Turkish people covered medical insurance by government.
Oh, thank you. Thank you.
By the way, in Thailand, who take the ultrasound?
Yes. Previously, we follow like you just mentioned that we can perform ultrasound by ourselves, but because of the sensitivity and specificity, and then we are not the the radiologists. We don't have any certification. We can perform ultrasound your bedside. You can do some basic procedure or like paracentesis or something, but for official ultrasound, we need radiologists. And wait time is maybe 6 to 8 months for the ultrasound.
Thank you. And
thank you.
Okay. Well, there may be more questions, but because of the shortage of time, I want to close this session, this state-of-art lecture by Professor Tawandi. Thank you very
so
much.
Thank you.
Next part is chaired by Dr. Kadil Ndukmasi.
It's great honor for me to chair Professor Diana's session. I would like to give some information about the Professor Diana. Also, she is the queen of the apostle. And she graduated medical school and she trained in the gastroenterology and digestive endoscopy in University of Santo Tomas, Philippines. She got a Monbusho scholarship as mine. Monbusho scholarship is the Japanese government scholarship, and trained hepatology in Tokyo University. Also, she took diploma for the leadership in medicine from Harvard Medical School. She was the past president of APASL and different Philippines medical associations. Currently, she's the director of Asian Pacific Digestive Week Federation and chairperson of World Congress of Internal Medicine, and also member of Steering Committee of APASL, and also associate editor of Hepatology International Journal and editorial board, World Journal of Gastroenterology and Philippines Journal of Internal Medicine. Okay, please, Diana.
Thank you very much, Professor. Professor Dokmeni is one of the pillars of Apostle, and I'm very fortunate to work with him. I thought I'm the princess, not the queen. Okay, I'm giving the talk on unraveling the crosstalk, and that is understanding the interplay between MAFLD, pathogenesis, and treatment strategies. I have nothing to declare regarding this study. So before you is the prevalence of MAFLD globally. It's about 36.7%, and about 5% are seen in lean MAFLD, and 29.78% in non-obese. And on the left side of your screen, you can see that about 4 million patients with MAFLD are seen, and this is going to be a burden as far as our healthcare system is concerned. And here you can see that about 50% of patients, or 41%, does have hypertriglyceridemia, and about 43% also had hypertension, and about 22% actually has diabetes. But this seems to be different in my country. In my country, it's more diabetic patients and obese patients rather than those with hypertriglyceridemia. What is evident in the Asia-Pacific region is that there is a changing prevalence, a growing trend. Because of, we used to say that most of the liver diseases in the Asia-Pacific region is due to viral hepatitis B and viral hepatitis C. But because there is a massive vaccination program that is being required by WHO among the government in the Asia-Pacific region, of which hypes about 90 to 98% should be vaccinated. And because there are very good DAAs that can actually eradicate hepatitis C, you can see now that the changing prevalence of MAFLD is the growing concern as far as liver diseases in our region is concerned. And this is across all areas, all countries on the lower left side of the screen, from mainland China all the way to Malaysia. So this is something that will worry us in the next few years. And if we do not see and understand how we can actually provide treatment and follow-up for patients with MAFLD. So the issues of concern that I'm going to discuss is the prevalence of MAFLD globally, the role of MAFLD in the metabolic syndrome, enumerate the treatment strategies among patients with MAFLD, and identify the gaps and challenges related to it. So this is the disease prevalence. Unlike the others, this is actually starting with a patient with a normal liver, and because of environmental strategies, they become steatotic, develop NASH, which is a risk for developing fibrosis, and eventually will have the foreground to develop even liver cancer. And below you can see the histopathological diagnosis or strategies that are seen in patients with MAFLD. Now, what is evident here is this is a multisystemic disease. You can see here that because there is insulin resistance or hyperinsulinemia and related disorders, meaning there are atherogenic dyslipidemia or patients who develop hypertension or metabolic syndrome. There is the activation of the vasoactive and thrombogenic molecules, such as fibrinogen and the transforming growth factor B. And of course, as you evident this, there are pro-inflammatory cytokines that seems to play a significant role in producing a multisystemic disease, such that you have cardiovascular disease, you have type 2 diabetes, patients who develop chronic kidney disease, or patients who develop even colorectal cancers. So this just reiterates our strategy that MAFLD is not isolated only in the liver diseases, but can be seen in the multisystemic organ system, both from cardiovascular, from diabetes, all the way to patients, even in those with the risk of cancer. So this highlights the or the mechanism of action that happens in a patient with MAFLD. There are increase in inflammatory cytokines. This then produces the so-called dysfunctional adipose tissue, or the WAT, and this increases free fatty acid, increases inflammatory cytokines, all the way now leading to patients with MAFLD. On the right side of your screen, this is the same issue, that all producing a risk to cardiovascular disease, from insulin resistance to atherogenic dyslipidemia, to those that activates the inflammatory cytokines or the oxidative stress, producing now a cardiac autonomic dysfunction, and therefore there seems to be a structural electrical remodeling producing arrhythmia. So in essence, in a patient with metabolic associated fatty liver disease, there seems to be a growing incidence of patients who develop cardiovascular, who develop renal disease, and of course, who develop other pathologies that are related to it, producing a multisystemic disease. So when you look at it in a haystack, if you look at the patients who are full MAFLD with cohort, and you identify those with no cirrhosis, with compensated cirrhosis, and with patients who develop decompensated cirrhosis, you can see that a lot of them will take over years to follow up. And therefore, this seems to be a problem such that we need to turn so many things to need to follow up so many people to find just one case. And this is evident by the number of cases you develop if you have a patient who develops, if you start patients on the natural history of a community-based study. So this is what we want to assess, whether it is evident for us to be taking care of patients in the community, because that will actually burden the healthcare system, especially with a limited number of hepatologists. On top of that, you can see here that as you increase the number of metabolic syndrome criteria, you increase the prevalence of free fatty acid, of fatty liver disease. About 14.3% of patients do have normal ALT, but 4% only have advanced fibrosis, showing the fact that it directly correlates that the number of criteria that is present in a patient with MAFLD is actually congruent to the number or the prevalence of fatty liver disease. Subsequently, here is a systemic, and therefore it is evident for us to be able to find out who among our patients we should clearly or follow up through the different strategies that we have. One is, I mentioned, the number of metabolic syndrome criteria your patient has. So that seems to be one factor. Another is fibrosis. And here is a systemic review and meta-analysis that fibrosis, and I think you've heard this in all over the steatotic or the fatty liver conference, that it is important to monitor patients on the different liver fibrosis stage. And the reason for that, it is directly related to all-cause mortality and liver-related events. So fibrosis is indeed a key prognostic marker, both of mortality and liver-related morbidity. Subsequently, this was followed up. This is a biopsied, confirmed MAFLD, followed up for 4 years, and F3 and F4 fibrosis by the liver fibroscan showed that fibrosis is associated with increased risk of liver-related complications and death. In other words, if we label as hepatologists this specific group of F3 and F4, follow them up, then probably we can give to our primary care physicians those patients with the lesser F3 and F4, like F1 and F2, may be given to them so that they can be able to be followed up properly. So these are the recent guidelines on who to screen. Apostle is quite unique in that the risk of patients such as overweight, type 2 diabetes, and metabolic syndrome. So I mentioned if your patient belongs to this. And on the right side is how do you screen these patients? The imaging tests, the blood biomarkers, the scores, or even biopsy. The AASLD actually screens for advanced fibrosis. And these are patients with type 2 diabetes, metabolically complicated obesity, patients in the context of moderate alcohol use, first-degree relatives of patients with cirrhosis due to MAFLD, and all patients with hepatic steatosis or clinically suspected NAFLD and the presence of obesity and metabolic syndrome. So if you look at this, this is a big bulk of our care. And this probably will strain most of the hepatology clinics because this will tell us that when you label your patient on this subset, this becomes now a problem. So the primary risk assessment is used on the right side using FIB-4. And just this afternoon, I've heard that FIB-4, they are using now a new scoring system in the US, the SAFE score, which isolated patients because of the very high fallout or the low sensitivity and specificity of FIB-4. The secondary risk assessment is using the transient elastography, and you repeat FIB-4 every 1 to 2 years in pre-diabetic patients or 2 or more metabolic risk factors. And this tells us that if you label your care on this subset of patients, on those patients with overweight, type 2 diabetes, and metabolic syndrome, then probably you can help now in understanding how to follow up these patients. These are different non-invasive or NITS tests that are available. Of course, the serum biomarkers are available randomly. And you can see here that when you take care of it, usually all of these elastography techniques are available in liver clinic. I used to remember because we were using elastography and it was brought in, not in the liver unit, but in the radiology unit. And this is where now you see that radiologists do not know probably how to interpret it. So this is one step for us to decentralize ourselves, teach our colleagues how to monitor patients on using elastography, because most of the time, especially for RFID, this seems to be where the radiologist or ultrasonographer would really play a significant role. And just this afternoon, you can see that ultrasound, I do a focus ultrasound, and we can do it in the clinic. In my country, our country is an archipelago, and for a patient to go back and forth for a do ultrasound and then come back for follow-up, it takes a lot of effort. And therefore, probably using strategies that may be a point of care and identifying patients early on for fibrosis will really make a difference as far as healthcare system is concerned. So in essence, if you have a patient who is identified in the primary care physician or in the endocrinologist or a friendly cardiologist or even in the wellness clinic to develop muffled, or these are the identified three factors. This is presence of obesity or those presents with diabetes or those who are actually metabolic syndrome. You now try to see using the liver fibrosis severity of the low risk and the high risk. For the low risk, these are patients who are in the fibrosis of F0 to F1, and this is where primary care setting would play a significant role. In those patients who have high risk, these are patients in the F2 to F4, and this is where our specialist care comes into play. So how does the metabolic scenario of progressive muffled comes in? Now, I included this because this is where the different drugs come into play. You can see here that free fatty acid, the increased hepatic delivery of free fatty acid in the liver now produces a high triglyceride accumulation inside the hepatocyte. And this is because there is de novo lipogenesis, an increased esterification of the free fatty acids. Of course, genetic variants do play a role, and of course, oxidative stress. And when you look at the de novo lipogenesis, this is where your patients have increased uptake of glucose, or patients with diabetes, the increased uptake of fructose. There was a lot of conversation on this, whether fructose actually really have its effect directly in patients who develop muffled. And of course, those patients who have increased release of the so-called inflamed or hypertrophic white adipose tissue, or the WAT, producing insulin resistance. So in essence, when you take care of patients with progressive muffled, you look at it in the perspective of hitting different targets, different comorbidities that do play a significant role, because just like in viral hepatitis, if you remove the etiology, then probably it can play a significant improvement in the outcome of patients with muffled. So drugs that hit on the increased uptake of glucose, drugs that hit on reductive oxidative stress. And of course, now there is a lot of hype on the gut microbiota, the release of the DAMPs, the damage-associated molecular pattern, as well as the pathogen-associated molecular patterns, all producing now reactive oxidative stress that do play a significant role as far as progressive muffled is concerned. So, but central to this is fibrosis. And when you talk of fibrosis, it is the activation of the different pro-inflammatory cytokines producing now an activation of the hepatic stellate cells, producing now the collagen formation that is responsible for those patients with fibrosis. And therefore, the way to look at it is first is to assess for the risk factors, the type 2 diabetes, metabolic syndrome, or obesity. And in some areas, you need to exclude other causes. You, at this point, because of resource-limited countries, we do use the first-line assessment of FIB-4. And if your patient has a FIB-4 of less than 1.3, then it's a low risk and you need to just repeat your NITs. However, if your patient is in FIB-4, 1.3 to 2.67, which is the cutoff, you need to undergo a liver stiffness measurement. And here you can see here that the message or the specialty of care comes if your patient is in moderate, this is in 8 to 12 kilopascals, and especially if your patient is in the high risk. Of course, if your FIB-4 is more than 2.67, then there's no reason for you to do a subset of using the liver stiffness measurement and go straightly to a specialty care center wherein monitoring of these patients as far as progressive NASH or muffled is concerned. So the key factor in evidence right now is regression of fibrosis. And you can see that the removal of etiology agent is very important. This is when you have a major issues of decreased interleukins, the decrease in TGF beta signaling, and of course, the decrease in the synthesis of ECM components. This then, if you hit on agents that causes the fibrosis, then probably you can have a regression of your fibrosis. On the right side, you can see the different areas where now evident that there are some drugs that hit on the different fibrosis strategies, but unfortunately, this seems to be more time as we see drugs that are related to fibrosis regression. So the lifestyle guidelines in MAFLD are as follow, and this is actually the same because it hypes on obesity, type 2 diabetes, and cardiovascular disease, and all of them hypes of lifestyle modification. So I will give a specific interest in this. Dietary change and weight loss and structured exercise are key factors that are evident in patients with MAFLD. Of course, limiting your calories into 500 to 1,000 kilocal energy deficit to induce a weight loss of 500 to 1,000 grams per week. Weight loss of 7 to 10, this has been released or associated with reversibility not only of steatosis, but also of fibrosis. And a moderate intensity exercise of 150 minutes a week, both aerobic and resistance exercise. And a while ago, they were recommending a resistance exercise for a cirrhotic patient. Quite interesting, but difficult in the real world. Of course, a resistance exercise needs to do a lot of bending and all of this and weightlifting, which probably will be a factor, especially if your patient has already protein loss. Weight loss of about 7 to 10% has been shown in this prospective study of 293 patients with histologically proven non-cirrhotic patients who actually have a reduction. And you can see here that it is not only steatosis that is reduced with the 7 to 10% weight loss, but also a regression of fibrosis. So it is not the drugs that is important to reduce or have a regression of fibrosis, but it is the weight loss that will actually be evident, leading to resolution of NASH and improvement in fibrosis. But you know for a fact that if you take care of patients that you need to advocate weight loss, it is so difficult for them to be maintained on such. And in fact, even for yourself, even if you lose some weight while eating and having a sedentary lifestyle, or even just one big event like Easter, on Easter, everybody will be having a party after the long week of Holy Week. So this becomes now a factor as far as maintenance or producing now a strategy that will be a key factor to maintain the 7 to 10% weight loss. Of course, as I mentioned, a Mediterranean diet is isolated, and this is an increase in the fruits and legumes and beans that is evident. This is the intervention of Mediterranean diet versus no intervention. Both the short duration of study of 6 months to even the longer duration at 18 months has shown to a decrease in intrahepatic fat, showing now that you can actually reverse your liver fatty liver index, your HOMA score, and even your liver stiffness. So the approaches for current available therapies are as follows. The weight loss I have reduced, and of course, other approaches potentially reducing the end-stage complications to treat type 2 diabetes and cardiovascular factors, and of course, liver-directed treatment. I will just come in with some strategies that have been in the market right now. And this is the first, the glucagon-like peptides that have been a hype in every center. And most of us know for a fact that semaglutide has shown a NASH resolution at 0.4 milligrams per day, the best actually, with NASH at phase 2 trial with resolution, but no improvement in fibrosis. And an often asked question, is it the drug itself, or is it the weight loss that was produced by the drug itself? So this is something that hypes on semaglutide because it has produced quite an imaginable number of patients who lose weight. But I think the caveat here is that you produce the side effects related to it. There are some patients who cannot tolerate the drug. It's nausea and vomiting. And of course, the fact that it is difficult to find right now, especially that some patients are not using it for diabetes, but actually are using it for weight loss. And that is why MAFLD development is intimately correlated with the GLP-1 signaling pathway, and that the receptor agonist is effective, producing both cardiovascular and type 2 diabetes outcome. What about the sodium glucose reabsorption? And this is where you actually pee your glucose. And you can see here that they have shown an improvement of steatosis, the empagliflozones, and even in some patients, the dapagliflozones, showing an improvement in liver steatosis and fibrosis. But the side effect of this is a profound adverse effect for UTI and fungal infection. And this is where now the safety profile of this drug is being questioned for patients with MAFLD. What about patients on the PPAR? PPAR has been in effect, has shown its dramatic improvement, especially the pioglitazone study. But you know for a fact, the side effect of this is a weight gain, both in women, which is actually what we do not like to have in a patient who is having problems with obesity. So the PPAR is an overall safe and tolerability of these drugs are good, but the minor adverse effect does require further investigation. These are the FXR drugs hitting on obeticholic acid, showing both a lipid increase abnormality, and that is why it is not being used right now, as did not get an FDA approval because of the side effect of mild to moderate pruritus that may cause liver, and also has some evidence that may cause liver damage. And this obeticholic acid reduced the markers of liver inflammation. However, the long-term safety issues should be considered. And lastly, just like all the other drugs in the market, they lack efficacy or still are under trial. But lo and behold, there is a new drug that was approved by the FDA just 4 days ago, and this is the resmetirom. This is a thyroid hormone receptor that is responsible for regulating the metabolic pathways in the liver and is frequently impaired in NASH. And patients with NASH have reduced levels of thyroid hormone activity in the liver, and the result now in impaired hepatic function. And the recommendation is a once-a-day liver-targeted drug. And lo and behold, this have shown a significant greater relative reduction from baseline in hepatic fat. And this even increased the rate of NASH resolution and even fibrosis resolution in the recently published New England Journal in 2024, showing now that this is the first FDA-approved drug for metabolic-associated fatty liver disease, or a patients who have biopsy-confirmed NASH. This is something that we need to see. Of course, these are studies, but we need to see the real-world scenario as this is going to be launched in the next few months. So, but evidently, I think basic to this is how we can prevent and isolate patients, both in the primary and secondary role. So I think what is evident here is if you see patients or if your colleague has seen patients in obesity, metabolic syndrome, or type 2 diabetes, you do screen these patients, and you do refer only patients who have already the risk of developing F3 and F4 fibrosis. In evidence also is the care that this is a multidisciplinary approach to patients with MAFLD, showing not only the internist or your primary care physician, but also the cardiologists and the nephrologists do managing the cardiometabolic or comorbidity in patients with NAFLD. So in evidence, it is necessary for us to evaluate the patient's benefit and cost effectiveness of a multidisciplinary models of care, especially in our community, in my setting, wherein everything is out of pocket. You refer a patient to a specialized area or like a nephrologist, there is a separate bill. So this has to be taken into context as far as healthcare system is concerned. Implement the context of specific, and I think this is where we play prevention, screen, and risk stratification before treatment. And I think this is where preventive hepatology does play a role as far as our care of patients are concerned. And lastly, provide a clear guidance endorsed both by the relevant professional societies on preventive hepatology. And of course, this is supposed to be done by our primary care physician. So in essence, primary care endocrinologists, the first step is identify patients at risk. Secondly, the history will tell us whether there is a patient who has excessive alcohol drinking and the different laboratory or liver function tests. Do your NITS score, isolate patients with fibrosis, and only patients at high risk should be patients referred to our center. So here on this left side of your screen, primary care physicians do play. Only those patients with very high FIB score gets into the hepatology care. And of course, as our role is to risk stratify our patient, identify patients who have progressive MAFLD, and of course, instigate now strategies that will reverse it. So lastly, we need to have tools. And I think this is where we have a tool on hand that will help our primary care physician identify patients in the clinic so that you can actually have a referral system. So here, it tells them in a simple guideline, what is it, who are at risk, and the symptoms, and how to diagnose this. This is a simple tool that you can actually share. It is online, and Apostle has done this. So lastly, in summary, Mr. Chair, MAFLD has been recognized as a global chronic liver disease, and it is associated with the fatal trio. The fatal trio is actually overweight, type 2, and those patients with metabolic dysregulation. And because there is a rising in obesity and diabetes, it is an emerging chronic liver disease. And as I mentioned, it drains our healthcare system, and that is why 25 to 30% of the global population will have this in the next few months or years. And therefore, we need to do preventive measures as far as this is concerned. It is a multisystemic disease and therefore requires a multidisciplinary approach. The MAFLD-related liver fibrosis has been identified as the strongest predictor, and therefore you need to keep on monitoring your NITs. Cardiovascular disease is the leading cause of mortality, and therefore they should be placed also in a care of a cardiologist. And lastly, as I mentioned, the MAFLD-specific treatment doesn't exist, and therefore a structured system and interventions for control of comorbidities is evident. So lastly, the pioglitazone is advised for MAFLD patients, whereas the vitamin E is advised for non-diabetic MAFLD patients with more than F2. Resmetirom is a drug that was approved recently and seems to play now a significant role for patients who have developed MAFLD. With this, I'd like to thank the organizing committee, and I'm happy to take some questions. Thank you for your time.
Thank you very much. Excellent talk, as always. And this is the state-of-art lecture. Then there's no question. And also, we have the limited time, okay? Thank you very much.
Thank you very much, sir.
Thank you very much, moderators and lecturers. This concludes the second day of APASL 2024 Kyoto, the Center of Hepatology. Thank you very much for your attendance once again.